COVID-19 in children for primary care. My name is Janelle Dever. I'm one of the Executive Directors at Northwestern Melbourne Primary Health Network, and it's really great to have you here today. I'll just take you through some welcome slides before introducing you to our panellists. But before I do, I'd really like to start by acknowledging that we're meeting on Aboriginal land today. I'd like to recognise their continuing connection to land, waters and culture. And I'd like to pay respects to elders past, present and emerging, and also to any Aboriginal or Torres Strait Islander people who are here with us this evening. Now onto the slightly boring bits, some housekeeping. All attendees are muted, so make sure you take yourself off mute if you're going to ask a question when we get to the Q&A. We'd love to hear your questions, and there will be time for questions and answers at the end of the session, but we'll also use the Q&A boxes circled here on this particular slide. And if we can, during the session, we will answer whatever questions we can, and as they are answered, they will start to appear so you can see them. Otherwise, I'll be in the background looking at the questions that are coming through and keeping track of themes so that I can facilitate that at the end of the session. And just to let you know that this session is being recorded so we can make it available for people who aren't able to attend tonight. And just one last thing, just a tip to ensure that your name in the Zoom webinar is correct. We've seen some very entertaining names following homeschooling with the kids using parents' laptops, so just a heads up there. So tonight we've got a fantastic lineup. So we've got the first topic is really focusing on an update on the COVID-19 pathway. Now, speaking from being connected to this pathway since August last year, there have been many changes and updates along the way, and we'll hear from Alistair about improvements to that and the role of primary care. And then we'll have a session, Shidan will talk to us about the managing COVID-19 in children, which is obviously something that we're seeing differently to what we saw in 2020. And as I mentioned, there'll be a Q&A at the end. So I'd like to introduce our speakers. I'd like to thank them very much for attending tonight. And Alistair, who got roped in at the last minute because unfortunately Nicole Allard is unwell this evening, but Alistair comes to us from the Royal Melbourne Hospital and Peter Mac. Alistair is a respiratory physician and has a strong interest in smoking-related lung disease and streamlining access to care. And I think COVID-19 has thrown in there for good measure over the last 18 months or so. Alistair is the clinical lead for the West Metro COVID positive care pathway, which just have to acknowledge Alistair's work in really driving that pathway, which has now really formed the basis for standardisation, certainly across metropolitan Melbourne, and has informed the statewide guidelines, which is no mean feat. And also Dr. Shidan Tosif, who's coming to us from the Royal Children's Hospital. So Shidan is a consultant paediatrician with a broad experience in managing health issues affecting newborns, infants, children and adolescents, and takes a holistic approach to health, enjoying working particularly with families to find solutions that best meet their needs. So we're very lucky tonight. And look, these are the people you want to hear from. So without further ado, I'll hand over to Alistair Miller.
Thanks very much, Janelle. So, look, I guess this is an opportunity to talk about the pathway and talk about how it's changed since July and August last year. Talk about the really crucial role that GPs play and how we can help you all care for your patients in this context. As Janelle said, the slides that we've got were put together by Nicole Allard, and she certainly has some expertise and some interest in vaccines in this space, and I'll talk briefly about those, but really just to inform the changes that we've made to the pathway, and talk a bit more about the medium pathway and what that looks like these days, and I guess some other changes that are coming that we're hopeful will be really useful for primary care. We'll just go to the next slide. So look, the general structure for the COVID positive pathway hasn't changed a great deal since it was originally conceived back in July last year through a collaboration between the PHN, CoHealth and the Royal Melbourne Hospital. And I guess what we've changed in recent times is trying to make it more streamlined so that we're able to assess people who are most at risk of severe disease, and get them into care as soon as possible. And that's being done in a number of ways. And what we're looking at is that particularly as the vaccination rates go up, more and more people are going to be, as a proportion, going to be vaccinated. And so we're looking at how we might use that vaccination status to better risk stratify people. The original model had 3 levels of care, and as you'll probably know, the vast majority of that care was held in general practice last year in what we described as the low risk pathway. The medium risk pathway was managed by hospital services, and that now includes a maternity risk stream, which is a separate sort of model of care. And now also working, I have worked with the Royal Children's and with other paediatric services, looking at how we might also link in paediatric care in this space. And inpatient care remains initially in streaming hospitals, and now really every major hospital. There is a move now to have a new level of care, what we're describing as the low stream, and that's people who are self-managed, who are at very low risk of having severe disease. And so that's in relatively younger people who are fully vaccinated and without any comorbidities, with the idea that they don't need to have regular follow-up because their risk of severe disease is low enough that providing we're confident that they have adequate health literacy to seek help and have the capacity to do that, then they can manage themselves in the community. And next slide. And so I guess, Nicole was really keen for us to try and get a sense of how good the vaccines were. And certainly all 3 of the vaccines that are currently available to us do have a pretty reasonable protection against any symptomatic infection, but most importantly have excellent protection against either hospitalisation or death. And this is obviously much better with a second dose, but even with a single dose, the risk of hospitalisation remains lower. And certainly the numbers we've seen in hospital of people who are fully vaccinated is incredibly low as a proportion of the overall cases. But we are certainly seeing a number of people who are getting infected and remaining well in the community with that double dose. And next slide. So this is pretty busy, but really is looking at all of the vaccines that are available throughout the world. And again, what we're seeing is really high rates of protection against the more severe infection, which is really what we're aiming to reduce. But it also means, I guess, we need to be thinking about how we best manage these people. Next slide. And so one of the primary functions of, I guess, of the COVID positive pathways is to assess people and determine their risk for severe disease, and then follow them up in a way that corresponds with this risk. We've made some changes to how we risk stratify people, looking at vaccination really as the primary change. But we've also been looking at how we stream people for care so that they're able to get access to medications that are now available in the community prior to needing oxygen. Many of you will have heard about new monoclonal antibody, sotrovimab, which is available to people who are at high risk of severe disease. So people who are older than 55 or have comorbidities that put them at risk. But the crucial part of it is it's only approved and only really been shown to be effective in people who are in their first 5 days of their symptoms. And so identifying these people early is really very important, and clearly also encouraging people to get tested early plays into that. We certainly feel that there's a really huge role for general practice in identifying those people, the people that they know are at risk, and we're working on ways that we can best engage you with your own patients when they do test positive, because we're fully aware that the systems that are in place don't connect well with you all in the community, with your own patients. The systems have not been set up in a way that makes that happen. And so in the pathways, we are really keen to get people back to their own GPs who clearly know them best. Go on to the next slide. And I guess the health pathways have lots of information about all aspects of COVID care in the community, and that includes a more recent pathway looking at the care of children. So it has information on assessment of children in the community, has links through to services and how best to assess children, what sort of care children are likely to need, and how you might go about referring people, and what red flags are best to be looking out for. I won't speak too much about COVID in children. Shadowne is clearly the expert on that aspect. I guess one of the other things that is about to change in the West Metro area is that we're moving from a REDCap database, which has been our primary database for clinical information and transfer of that information between groups, but also our primary method of engaging with general practice in terms of care, in the form of symptom surveys sent out to you for your patients. And we're falling in line with the rest of the metro area, the other two pathways, using a system called COVID Monitor. Some of you may have had some interaction with this if you or have patients who are in either the northeast or southeast areas. COVID Monitor is a very different system to REDCap. While the assessment process will mirror very much the assessment process that's happening at the moment, it will allow much greater visibility over the patients that have been allocated to your care, and hopefully we continue to aim to get all of the patients that are known to you back to your care. It has the capacity to have whole of practice views. So if you work in multiple practices, you can see all of the patients that are allocated to clinicians within those practices, so that if people are not there on particular days, then they can be seen by alternate clinicians. It also allows for the recording of symptoms by the patients themselves. So it has a web-based app where they can input their own symptoms, which is visible to you within the COVID Monitor portal. So it gives you much greater visibility and much greater flexibility in terms of how you might follow them up. You don't have to do that. They don't have to do that, but it's an option for recording of symptoms and following the illness. We know that that isn't going to work for everyone, but it's an option there that enables that much greater visibility and flexibility. Because if you know that your patient has stable symptoms and is well, they're not necessarily someone that you need to be calling daily or second daily to check in on them. Similarly, if their symptoms change, and if they're putting in moderate or severe symptoms, the system sends an alert both to the dashboard, but also to a nominated phone number alert the user of a change in symptoms. And so it adds a degree of surety in terms of managing those people in a less hands-on way. So there'll certainly be some training around this made available as we get closer to that going live, and the PHN has really been crucial in advocating for the needs of GPs, and I guess we're very keen once we go live to get feedback as to how we might be able to improve it so it's better fit for GPs in this space. I'll hand back to Janelle.
Thanks, Alistair, for taking us through that. And I think it's probably a really important point, that last point. So Bianca Bell, our Director of Primary Care at Healthcare Improvement, who many of you will know is probably one of the strongest advocates for general practice I've ever met, and has certainly helped me build my understanding of life in general practice. And also Nicole Allard has been part of that process. So there has been a GP perspective built into that. And part of the reason why that's been so important is that in the Northeast and the Southeast, the COVID positive pathways haven't incorporated the GP low risk model in the same way that we have in the West Metro region. So what's going to be fantastic in the coming days and weeks is actually seeing greater standardisation across those three regions, the West Metro, Northeast and Southeast, to cover the whole of metropolitan Melbourne. It really gives GPs the opportunity to support their patients should they be able to and wish to do so, and their patients have nominated them to do so. We do think that moving to this new system will ultimately be of great value to those that want to engage with it, to give a real perspective, as Alistair has said, about how patients are tracking. And I think my understanding is, if this is correct, Alistair, that it will also include those patients that are in that medium risk, who may be in hospital care. So you may also get that, I guess, that visibility, which can be a bit challenging at the moment in terms of patients being in hospital care. You might only hear on discharge, and sometimes that doesn't always quite make it through as best as we would like. So we will absolutely support general practice in terms of the change management associated with this new system, and Bianca and the team are working very hard to make sure that the information is available. We're doing that in particular in partnership with Eastern Melbourne PHN, who we partner with for Health Pathways Melbourne, and we'll be developing, I guess, videos and things to support that process as well. And we will be making sure that communication comes out to you really clearly. And I probably just acknowledge as these changes happen, sometimes there are some teething problems. So we're certainly aware of even the recent changes to pathways, that there have been some challenges associated with, we did have a wonderful sort of warm handover process when we were in a bit more of a manageable case load, and currently that's presenting a bit of a challenge. So we're working through those with the various parties too. So just wanted to acknowledge that for those of you that may have been going through that transition with us, but there will be certainly change management support for this, using this new system, should you wish, but we hope it will give much greater visibility for primary care. So without further ado, we'll hand over to Shadan to hear about what you're all here to learn about as COVID-19 in children.
Thanks, Janelle. Can you see my slides? Okay, great. And thank you, Alistair, for that presentation. And it's really lovely to be here. Thank you for the invitation to present. And firstly, I just wanted to acknowledge all the hard work that is happening in general practice. I know many of you are seeing lots of children and supporting them, and we really appreciate that. And I look forward to sharing some of these slides, and also happy to discuss and think about ways we can continue to collaborate and work and support everything that you're doing. And I'll just give an overview of the spectrum of COVID in children, some of the treatment pathways, and the special considerations in terms of things to look out for in general practice. And I'll use a few case studies to try and highlight these different scenarios. And this is the first one. A 4-year-old with a runny nose and a fever for 3 days, diagnosed with COVID, a past history of viral-induced asthma. And I'm sure as many of you have heard from families, parents are asking, very concerned, what can they expect? Can the child infect other people in the household? Does my child need to go to hospital? And as an overview, just to answering some of these questions, I just wanted to highlight just the number of children that and young people that have been impacted by COVID. At the moment, we have almost 7,000 active cases in 19 and under in Victoria, and this makes up about 25–30% of the overall number of cases, so quite a high number. In children, we see essentially symptoms that are very consistent with any other viral infection. COVID presents with fever, cough, sore throat, and rhinorrhea most commonly, and a significant number of children may be asymptomatic. The median illness duration is about 5 days in younger children, 7 in older children, and typically they make a faster recovery than adults. And in terms of addressing some of the parental concerns, especially when Delta strain arrived, we were worried, or there was concern that there would be a difference in what we were seeing with the clinical presentations. And so far, that really hasn't happened in terms of seeing a greater proportion of severe disease. What we are seeing is a higher transmissibility, as I'm sure you're well aware. The virus moves a lot faster through households, and children previously used to be a less of a contribution in terms of transmission in households. And even now, they don't seem to transmit as much as adults do in the household setting, but they do transmit even in younger children. The number of cases overall and the proportion, therefore, the number of cases overall increasing in children, and that small proportion who are susceptible to severe disease, whilst very small as a proportion, may lead to more numbers overall. And I can speak to some of those numbers that we've seen at RCH. The hospitalization rates, though, have remained very low. I'd say in Australia, our hospitalization rates are down the lower end of that spectrum of 0.1%, and deaths are exceedingly rare. And this is similar to what's been seen in other countries such as the US and UK, who've had Delta longer than us, who've seen rising numbers of infections in children, particularly in secondary school-age children, but the mortality rates, thankfully, have been very, very low. And just to zoom in a little bit more in terms of what's happened in Australia, as I said, we've had across Australia, about a quarter of all cases have been in children and young people. That amounts to probably over 24,000 children. And in Victoria last year, we had over 3,000 cases, and many of the ones that presented to the emergency department required no medical intervention. And of those that were admitted, the admissions were very brief or precautionary. We did have a small number of children who had severe disease, and they all fully recovered. And you can see here on the right, the profile of the number of cases on the top, where the high numbers in the 19 and under age groups. However, thankfully, we've had very few deaths in children and in teenagers. So just moving on to the next case study, a 15-year-old presents with elevated weight, high BMI, with day 3 of COVID, with cough and shortness of breath, and that is the X-ray on the right, which is showing bilateral lower lobe opacification and pneumonia. This child, on the second day of admission, had worsening respiratory distress, required oxygen, then high flow and CPAP, and was transferred to intensive care. On the day 5 of admission, admission in the intensive care, was found to have a subsegmental PE and also a right leg DVT, was treated with Dex and anticoagulation and baricitinib, and made a recovery by day 9, enough to go to the ward, and a few more days before being transferred to hospital in the home. And so this is a case, obviously, of more severe disease in a child with risk factors. And I just wanted to use that case to highlight the spectrum of disease in children and adolescents. essentially, the spectrum of this disease follows that with any other respiratory infection, as I've said, with most children having a clinical phenotype of bronchiolitis, croup, or pneumonia. But the addition of COVID, which we're seeing in the very small numbers who've experienced severe disease, is in a way, particularly for adolescents, similar to the adult phenotype of the disease, where there is clotting risks and a need for respiratory support, particularly if there are risk factors such as obesity. So in particular, looking at the risk factors for severe disease, so children who you may see in your setting to keep a closer eye on, and then the pathways they follow may be different, as I'll come to in a moment. Essentially, these are older children, more than 12 years of age, who are unvaccinated, and those who have pre-existing comorbidities. And I just wanted to highlight obesity in particular, neurological disorders such as Down syndrome, that have really made up the majority of those children we've seen at the tertiary hospital setting who've needed intensive care. We haven't had at the Royal Children's Hospital any children who are adolescents who have been immunized. So essentially, those children who have ended up in intensive care are those with these risk factors and have not been immunized despite being eligible for the vaccine. What we see in other countries where they've had a longer experience with severe COVID in children with risk factors is that the risk, thankfully, is still low of severe disease and of mortality still extremely low. However, they are a group to keep a closer eye on. And just to highlight, children living with disadvantage or at low socioeconomic demographic background are also at higher risk. So I know there's a lot of discussion about pathways, and it was nice to hear about all the interesting changes that will be coming with the pathways that Alistair highlighted. And I don't want to confuse things, but this is a pathway that we have put together more as a clinical practice guideline to link in with those pathways across the metropolitan area. This is, I guess, a hospital pathway and is appropriate for RCH and Monash. And we have put this together so that you can see in a kind of traffic light fashion which are the kids that we would like to be connected with and those that need to be referred for the emergency department setting. The low-risk children, obviously those who are asymptomatic or mild disease, and these form the vast majority of children. Those with higher risk comorbidities that I've mentioned, or those with moderate illness, and in children that generally manifests with respiratory distress and increased work of breathing. And then obviously those with severe disease, neonates who are febrile under 28 days, or those with symptoms of PIMS-TS should be referred for further assessment. And kind of just following on what Alistair highlighted, this is the Department of Health pathways. And just to kind of pick up some of the differences between this guideline and the adult versions is that we do have this group, which are the family household self-monitoring, as well as the low-risk household pathways, which are where most children will fit, and that parents, we are in the top category will be the ones looking for and monitoring their children. And then obviously with the second tier, those that you will be involved with, and then the medium risk are the ones that start to enter those that are considered for hospital in the home. There's additional matrices that go with those guidelines, which I probably won't go into detail, but I'd be happy to share the references. And obviously this links in with the PHN guidelines that we just saw. And there's more detail in terms of the conditions and the risks and the determinants which determine which pathway the child will follow. And then just to highlight the additional category which is covered in this pathway, and I'll also touch on further in terms of what to do when children are sick with COVID, but not unwell enough to need hospital, but the parents need hospitalization. And I'll come back to that in a moment. Just onto the third case study. This is a case study of a 12-year-old who had mild COVID 4 weeks ago and then presents with a new onset of abdominal pain, rash, and fever. The fever lasts about 2 or 3 days and they present to hospital, found to have a very high CRP And I'm sure you can see that this is a case of PIMS-TS or MIS-C, which is an inflammatory condition which can follow between 3 to 6 weeks following COVID. And even though the initial COVID infection may be mild, this tends to follow a clinical phenotype similar to Kawasaki's disease, which you may be familiar with. However, generally we're seeing PIMS-TS and PIMS-TS or MIS-C present in older children, as opposed to Kawasaki's, which is generally in younger children under 10. The treatment for this at the first stage is IVIG and consideration of steroids. And this is just an example of this child's fever chart, which shows, you can kind of see here, where when the IVIG was administered, kind of hitting that fever, and that child made a full recovery. Our pathway for these children is then to have a follow-up echo 4 to 6 weeks later, and they stay on aspirin until we ensure that subsequent echo doesn't show any coronary artery disease. The other complications to look out for is long COVID. There's been a lot said about long COVID in all age groups, but in children and young people, whilst initially thinking that this was, affecting a significant number of children, as we've had better quality data, that proportion that we think have been truly impacted by long COVID has become smaller. Certainly, it is a real condition that follows COVID and has the phenotype of chronic fatigue syndrome or fibromyalgia, which affects adolescents in particular. And we have a pathway for this through our hospital, where you can refer any cases who've got prolonged symptoms for assessment, and that is at the through the RCH COVID follow-up clinic. I just popped in here that whilst PE and DVT seems to be mainly in the acute phase of infection, if we have large, overweight adolescents who are very sedentary following COVID, we have had an instance of having a PE late. So just as another kind of thing, just to flag. And finally, the fourth case study in an unvaccinated family where there's a 6 and an 8-year-old, the parents become progressively unwell. The mother is admitted to an inpatient ward and the father is admitted to intensive care. And this is really a challenge because the question is, where do the children go? And there's a couple of options for this, and one which on that previous slide with the pathway, there is a bit more of a flow on the options to consider. But I'll just say that the indirect impacts for COVID on well-being and anxiety in children and young people has been very significant. This has also been visible in the education gap due to disruptions to education. And there's a disproportionate impact on those who have been disadvantaged, those who are students with disabilities or mental health issues, and those who are vulnerable children. There are also the social risks and the impact from COVID with social isolation and risks of kind of child protection concerns, and particularly for children where they're at home with significant disability, where they may lose their carers if they have COVID, even though they may not be particularly unwell, the number of supports that they may still be able to receive at home may be impacted. So in terms of these situations where parents may be admitted leaving children without alternative carers, there's a couple of considerations here. Generally, we always request that at the intake period, care arrangements be considered with the parents in the event that they're hospitalized. So this may be with vaccinated other adults, family members. There are other services such as a family finding service, which is available. And there's also the La Trobe private hospital, which has a limited number of beds for admissions for children with COVID who are well enough not to need any other supports or interventions for short periods of time. If the children have complex medical needs, they would obviously need to be admitted to a tertiary hospital. So just to finish with the main points that I would like to offer for tips in primary care is to really assess the clinical syndrome that the child presents with and view this as you would any other respiratory infection. Most of the children will be mild, and if they have moderate or severe disease or significant comorbidities, there are other pathways through the moderate categories for those children to be linked in with. Look out for the red flags for PIMS-TS or signs of thromboembolism. And just a flag to consider alternate and coexisting diagnoses in children who have a positive test for COVID. And this is because there may be another reason why the child is unwell rather than COVID, which could be treated, such as sepsis or meningitis. And it's good to keep an open mind about those things. I won't go too much into the hospital treatment, but essentially we predominantly use respiratory support and corticosteroids, and there are some other agents which are available on a case-by-case basis. So with that, I'd just like to thank you again, and look forward to any questions and discussions. Thank you.
Thank you, Shadan. Now I hope I'll ask my trusty helper, Claire, just to make sure that there are no questions, because I can't see any in the Q&A. But it's probably just worth mentioning that I guess the point about household management, and essentially what we've seen because of the increase in the number of younger patients, is that the approach is to look after the household. We heard very loud and clear last year that families found it very difficult when they're receiving multiple calls from multiple different people, whether it be public health, Central Department of Health, Pathways folk. And so that has really been streamlined to look after the whole household. So I don't know whether there was anything, Alistair and Shadan, that you wanted to add in terms of household management and how that's being, I guess, monitored outside of what's already presented.
I think generally, in terms of household management, I think it's such a valuable approach because of, as you mentioned, all the different directions that families get messaging from, and that in itself can be quite cumbersome. And generally, thankfully, the children who have mild disease can be kind of tagged along and observed in the household very well, and that's what we've seen from our, sometimes people say they're kind of bouncing around in the background with mild COVID, as Nicole has often said when she looks at those families. And so it does make sense, absolutely, for the household to be considered as a unit. I think the instances where these those kind of moderate, severe tertiary pathways may be required are those, more severe kids or those with comorbidities, and those are the only points that you might want to consider those other pathways. But Alistair may also have more comments based on his experience.
Yeah, look, I'd echo that absolutely, and I think our assessment process has really shifted to try and do those assessments as a single household, and rather than trying to assess children individually, assessing them as part of a household, and ensuring that there are other people there who can escalate care if needs be. I think one of the features of COVID Monitor, as I said, is this symptom monitoring system that patients can enter their own symptoms. And there is a pediatric module, a pediatric questionnaire that can be filled out by older adolescents, if they have their own devices, or can be filled out by parents for children. Again, just so you have that oversight of how people are going, if people choose to do that. And I guess that's really across the board now in Metro Melbourne. Everyone is taking a very similar approach and really trying to limit the amount of, number of phone calls, number of contacts, so that people can actually just get on with it.
Yeah, I think that's absolutely right. We do have a few questions that have popped in the chat there, Shadan. I know you're in the process of answering. Oh, looks like one has been answered, and hopefully you can all access that, which is great. So I might just go to Jacques' question. With assessment, monitoring and management organised so well, is there really a need for booster now? Why not wait until the data indicates a need closer to next winter? Who wants to take that one?
Oh, look, I think it's a really hard question, and I think it's pretty valid. I think everyone is just a little bit worried about antibody studies that suggest that for some people at least, the antibodies that are detectable do tend to wane over time, and we don't know, exactly who that's going to be for or how long that is. But certainly while we've got this number of cases, I think everyone is pretty keen to know that at least our high risk populations are well covered.
Excellent. And another question there from Liliana about just thank you for an informative presentation, but interested to know what percentage of children are presenting to hospital from compromised populations with socioeconomic and consequent comorbid presentations.
Thanks, Liliana, for your question about the proportion of children who are from higher risk populations socially, I think is your question. And so in terms of social admissions or social presentations, we are seeing very small numbers. I wouldn't say they make up the majority of children who present to hospital, I would say, are those who have a kind of medical or clinical need. We have had very few admissions purely for social reasons. I guess part of your question may be how many of those children with COVID also come from those socioeconomic challenging backgrounds, and generally, I think the cases have followed where the highest number of the children impacted follow where the highest number of cases have been in the community, and we have seen in some low socioeconomic demographics or non-English speaking background children from those families that they are a little bit overrepresented in what we're seeing in terms of presenting to hospital. I think that's partly also because sometimes the lower health literacy or leads to lack of vaccination and those sorts of things, particularly in the adolescents, have impacted those children who may have otherwise been eligible and who haven't been vaccinated, for example. So I think it is happening. I think it has an effect in terms of what we've seen. As a side comment, we know in New South Wales, they have had a different approach to admitting children who have had a need for social admissions. They've had a much more open approach in terms of admitting those children to hospital. And that's made up, when you look at their numbers and you see they have a higher proportion of admissions to hospital, a significant component of that is social admissions. Whereas I'd say for us, we have, because of the not more robust, without comparing, but just we have a different approach here, and the social admissions have been supported largely through the community, which is where we've really wanted the kids to be looked after, rather than bringing those kids out of familiar environments into the hospital, if that makes sense.
Thanks, Sharon. And there's another question that's popped up about the booster when it's introduced, whether it requires a blood test to check for immunity.
Look, I haven't seen specific guidance, but I wouldn't have thought so.
No, we certainly, I haven't seen. It's not currently in the guidelines to receive a antibody test prior to any vaccination. And I would just highlight sometimes an antibody level, as I'm sure you're all aware, may not accurately reflect the degree of immunity that someone may have following a vaccine. So it's not the best predictor whether you have a high level or a low level in terms of how much protection that confers. I think the numbers that Alistair showed are probably a better assessment in terms of post-vaccine protection.
Thank you. And I think there's a lot of questions about boosters we still don't quite know the answer about, and just, often we hear the news at the same time you do with the media, and try and get the information out to you as soon as we can. So we do expect more information on that in the coming days. There's a few more questions that have popped in the chat there, so in the Q&A rather. In terms of a severe case, which one do you use? IV antibody, then immunomodulator, vice versa, or both?
So in children, I guess the mainstay of treatment is respiratory support for those with severe disease. And then the different treatments that generally are restricted to the intensive care setting are really on a case-by-case basis, and we don't have a set guideline for which immune modulator to use in which setting yet. I'd say the number of children that end up needing those immune modulating medications are a very, very small proportion. Dexamethasone, obviously, we use early when the child is on oxygen, but beyond that, those medications are very rarely used.
I guess in the adult space, anyone who is oxygen requiring gets dexamethasone at that time, and most will also get remdesivir, although the additional benefit for that is probably perhaps smaller than we thought initially. And then we've got a couple of other drugs that are used in people who have a sort of an inflammatory type picture. So baricitinib is the one that we use primarily at the moment, largely because tocilizumab is in incredibly short supply. In those who don't need oxygen, we now have sotrovimab, as I mentioned, and that's a monoclonal antibody against the spike protein. So essentially, like a instantaneous vaccine, and we're hopeful that will help to keep people out of hospital. The other treatment that has some evidence, and certainly if you don't get the sort of updates from the National Clinical Evidence Task Force, I'd recommend signing up for that. They're still constantly looking at new treatments and providing recommendations. And the other one is inhaled corticosteroids. The evidence is about budesonide, and one of the difficulties is budesonide on its own is not a treatment we use terribly much. Certainly in adults, I'm not sure how much it's used in pediatrics, but really all the nation's supply of budesonide has been snapped up into a few places in preparation for using it for people prior to needing oxygen. But there's some emerging evidence that it's probably a class effect, and other high dose inhaled corticosteroids will also be useful. Again, it's been recommended for people who have mild symptomatic disease, who are at risk of more severe disease, so people with comorbidities.
Now, there's two questions here that are on the same topic, and I'm living this joy at the moment with a child that went back to school, and day one was at school with a positive case. So we're having some fun at homeschooling just when we thought we were at the other end. But so a couple of questions really about either cutting the quarantine closure to shorter lengths of time, 5 days, such as primary care, given the low disease burden, and hopefully all the teachers and others are vaccinated, or not doing it at all. Thoughts?
These are just my personal thoughts. Yeah, I think this is it's a challenging situation when you've just got your kids back to school. They get exposed day one, and then it's 14 days quarantine. And what we know about the pediatric severity of illnesses as being very low, these decisions are obviously there to slow spread and prevent secondary transmission into higher risk populations. But from the child's point of view, yes, I mean that is it would be really nice, as they do in other countries, to only quarantine for a shorter period, or have permissions to come back to school once you've had a negative test, or only stay at home if you're confirmed to have COVID. These are all the things that are happening elsewhere. And I do wonder, as we become more familiar, leaving the aggressive suppression approach, which we've had in Victoria, into the kind of living with COVID, I do suspect some of these things, I hope, will change with time. Absolutely.
Well, they seem to be changing quite a lot, so you just never know.
Exactly.
There's a question around long COVID, and whether all COVID patients should be investigated, or only those that have symptoms, and what are the symptoms and any specific tests?
Yeah, thank you for that question. I think there's still a lot we are learning about long COVID, and the main symptoms I would say so far that have been reported are fatigue, concentration difficulties, memory loss, brain fog, also myalgia, headache, dizziness, and somatic complaints. There is no set diagnostic testing that is required. So I guess I would say to be guided by what the clinical presentation is. And overseas, there have been different forms of respiratory imaging, cardiac evaluation, and exercise testing, as well as a range of immunology investigations. From what we have seen here in Victoria, which is very, very few cases, I would probably suggest being guided by what the clinical presentation is and using that to dictate management whilst we wait for kind of more comprehensive guidelines. And as I said, we do have a COVID follow-up clinic where we're happy to see children, generally those with prolonged symptoms beyond 3 months, for assessment.
Thanks, Shidan. And I will copy into the chat some information we've developed for long COVID, but it's not pediatric specific, but geared towards general practice. Meredy has asked a question about COVID Monitor going live. Now, we may have lost Al, I'm not sure, but am I right in thinking this is next week, within the next couple of weeks is the aim?
Yeah, that is the aim. Sorry, my internet's gone again. The aim is for it to be the 8th of November or thereabouts. There is quite a lot that has to line up for that to happen, and I guess we're all pretty keen to make the move, because I think it has huge potential for improving visibility and enhancing care, but we need to be sure that it's going to be safe and indeed appropriate for us to use. So yeah, it is. Yeah, early in November is the plan.
I know that might sound a bit frightening too, because that's next week, right? So early November. But a big part of this too is certainly Bianca and the team working really hard to make sure that the right information is there for general practice to support that transition, because we know that if it doesn't work for you when you've got a million other things happening in clinics and vaccine delivery and so on, then that will be a real barrier. So that's really critical for us to make sure that works well, and working across the three sub-regions of West Metro, Northeast and Southeast to try and get as much consistency in messaging and functionality as we possibly can, so that, we know many of you actually support and care for patients that live across different boundaries, and boundaries mean nothing to patients and GPs who see people who come from wherever they wish to. So that's probably the critical thing. And one final question from Liliana, just may have missed this in the presentation, just curious to know what proportion of infants were presenting with COVID Delta strain and how that group was treated.
Yeah, thanks, Liliana. I didn't really address that in the talk. And what I would say is that the highest risk of hospitalization is in the age group of the adolescents. And then probably the second category has been in infants, although to a much smaller proportion. Those infants have generally been admitted for observation. They haven't needed intensive care. They're the ones that just have needed some feeding support or observation with a bronchiolitis type presentation. So I would say, I think it was important to highlight that age group. After the adolescents, probably those younger infants who have bronchiolitis is probably the second group to watch.
Thanks, Shidan. And do we know if long COVID syndrome is more likely in the unvaccinated?
I think that's a great question. And I haven't yet seen any research addressing that. I think it's you would assume it would be less likely if you're vaccinated and less likely to get severe disease or even become symptomatic at all. However, we need to see the data on that.
And I don't know if either of you can speak to this, but given there have been some concerns raised by actually numerous groups about vaccinations, particularly for pregnant women, are there any side effects of the vaccines to the unborn in utero? If so, what? And if not, is this something that's been considered? Or I know it's
it's certainly not my key area of expertise, but my understanding, and certainly we've spent a lot of time talking with our obstetric colleagues on care in pregnancy, and they are very confident that vaccination is safe in pregnancy, and certainly we know, and I guess this has been something that has been much more evident in this most recent surge, is that pregnancy is a very significant risk for severe disease. And so encouraging people in the early stages of pregnancy or in pre-pregnancy counselling to get vaccinated is really really crucial, and nothing to suggest any adverse effects, certainly for the mother, and nothing that I've heard of for the child.
Yeah, I would just echo that. Nothing at all in terms of concerns for the child, in terms of, you know, the many children now born of mothers who have been vaccinated, and just to highlight the much higher risk of COVID in pregnant women.
Fantastic. Well, thank you so much for your time, everyone. I think that's all the questions answered. Thanks for participating, those asking questions, and for being here tonight. I know everyone has had a lot going on for a long time, so you know, really great to have you along. And thank you particularly to our panelists for being here and sharing their wisdom and experience. So thank you. And also a little shout out to Claire, who's made everything happen in the background. So thank you very much. And just one last plug to fill in the evaluation form, please. We really want to learn how we can continue to make these sessions better, and want to know exactly what you want to hear about. So maybe pregnancy related to one again may be a good topic. And otherwise, have a good evening. And thank you for all the work that you've been doing. Good night.